Good evening, everybody, and welcome to our webinar on urogynaecology treatments. My name is Jan, and I'm the clinical nurse specialist in continence care here at Benenden. And I'm joined today by consultant gynaecologist, Mr. Abhishek Gupta. This presentation will be followed by a question and answer session. If you'd like to ask a question during or after the presentation, please do so by using the Q&A icon, which is on the bottom of your screen. And this can be done with or without leaving your name. Please note that this session is being recorded if you do provide your name. If you would like to book a consultation, we'll provide details at the end of this session. And I'll now hand over to Mr. Gupta, and you'll hear from me again shortly.
So we are here today to talk about what urogynaecology is and the treatments, and hopefully you'll find the talks a bit informative and what's pertinent to you, when to seek help, what we can do, what you can do at your level, and what you can seek help from the specialist nurses. And then you will also find it helpful about various resources we're going to share with you, and also if what treatment pathways are there, and when to seek surgical, and what's the aims of surgical treatments and non-surgical treatment. So hopefully we'll cover a fair amount of what urogynaecology treatments are. This is a bit about me. I'm a consultant gynecologist, and my special interest is urogynecologist. My NHS base is Benenden Hospital. I'm a lead urogynecologist there. And I have done my training in the Southeast London rotation, and my teaching hospital where I started the rotation was Guy's in St. Thomas's. And since then, I have done my advanced training in urogynaecology as well as benign abdominal gynae surgeries. And I'm also an active member of Urogynaecology Association, which is British Society of Urogynaecologists. And the unit in my NHS is accredited for urogynaecology services through BSUC, and we follow this almost the same pathways here at Benenden as well.
My name's Jan. As I say, I'm the clinical nurse specialist in continence care here at Benenden, and I've been in this role now for just over 15 years. I manage the specialist nurse team, and there's 4 specialist nurses here at Benenden. So we're very lucky that you have access to a really good specialist team. And we provide nurse-led clinics and also urodynamic assessments, which is a bit of a diagnostic test to make sure we're giving you the right treatment for your symptoms.
So what's included in this session? So we'll just talk about what is urogynaecology. We will also discuss about what common referrals we get. We'll discuss about the bladder problems. We'll discuss about urinary incontinence, which are various types of incontinence. We'll also explain you what assessment about the incontinence works. Then we'll talk about vaginal prolapse, and we'll also talk about briefly about recurrent urinary tract infections, which do get not very common, but do get referrals, and also patient resources and some question and answer at the end. So that's the kind of session overview. So what is urogynaecology? So urogynaecology is a part of gynecology where we dedicate for diagnosis of treatment of incontinence as well as female pelvic floor disorders, which are mainly incontinence, and not only incontinence, but sometimes the bladder also have other issues like urgency, frequency, which may or may not result in incontinence. It may or may not be because of prolapse of the vagina, but vaginal prolapse itself can cause other issues like uncomfortable feeling, bulge, dragging sensation. Then you have issues with recurrent UTIs, which may or may not be related to prolapse. And bladder pain syndrome is very interesting. That is usually, if it's not associated with endometriosis, we try to work with urologists rather than urogynecologist for bladder pain syndrome, because etiology is the same for men and women. So we try to work with our fellow colleagues urologists for the bladder pain. And obviously, when you have childbirth, especially when you have forceps delivery, another thing, you have pelvic floor injuries, which can cause problems with pelvic floor. And this is quite a big remit. And if what is said that roughly every 1 to 2 in 10 women will experience reportable issues with pelvic floor. And that's quite a big number. If you look at every 20 to 25% of the patients will come forward with reportable issues with their pelvic floor. But it also said that there is a vast number of patients who may or may not ever come forward, because sometimes people don't talk about it. But if there's a problem, if you're having issues, it's better to discuss this and if know that there's help available for you to improve your quality of life. And we all have to have our specialized training in the field of incontinence prolapse before we embark into any surgical treatments for incontinence and prolapse, because it's become quite a specialized field now. So the commonest referral we get is urinary incontinence. So it's either patients are referred for urgency, frequency, urgent incontinence, or stress incontinence, which is a leak when you get for cough, sneeze, lift heavy weights during sexual intercourse, or running or jumping. And this is when I say stress, is not mental stress, it's the physical stress. So, and more often it's not very clear that it is urgency, frequency, which can be because of overactivity of bladder, or stress incontinence, which is mainly weakness of the pelvic floor, or at the mid-urethral level weakness. Sometimes it's a mixed picture. So people do get mix of urinary incontinence, which is when you get problem of urgency, frequency, urgent incontinence, as well as stress incontinence, which is the physical stress. And sometimes they're a mixture of both. Then you also get referred for pelvic floor weakness resulting in prolapse, which is basically people typically describe as bulge in the vaginal area, or a dragging sensation, or you feel lump. Various patients describe it differently. I mean, commonly people describe as a golf ball, or some people require as a tennis ball or something like a bulge we are feeling. Patients get referred for recurrent UTIs, which may or may not be a result of prolapse, and we'll discuss that at the end. And for bladder pain syndrome, we usually refer our patients to a urologist, because they have a different pathway for these patients. And obviously pelvic floor injuries from post-delivery, which sometimes do occur in younger patients, which we have to see for deficient scar tissues, or prolapses even after they have had a trauma to pelvic floor, secondary forceps, or any difficult birth or a prolonged labor. So bladder problems. So let's talk about the bladder problems soon. So that is a diagram for what you describe as female bladder. So that's a female bladder. The two opening you can see in the dome is ureters, which are the tube which drains from kidney to bladder. Then you've got a pelvic floor muscles, and it's a two-dimensional picture. And the urethra, which is tube draining from kidney to bladder, from bladder to outside, which is what brings the urine out. At the mid of this, the female urethra is only 4 centimeters long, and the mid of the urethra, where you can see the pelvic floor diagram, that is when if I try to explain you from a stress incontinence, what is stress incontinence? If I try to explain you, just imagine my wrist as a bladder, and the tube which drains out as a urethra now. And in the pelvis, when your tummy pressure is increasing, or when you're coughing, sneezing, your tummy pressure is increasing, which is trying to squeeze that balloon which is full of water out. And this tube, which is the urethra now, which is a two-dimensional picture there, is going through just in your vaginal area. So mid-urethra, when the pressure comes from the top, when you're coughing and sneezing or jumping, there's a pressure coming from the top trying to squeeze that balloon out. But the same pressure is coming on your urethra. If you have enough support at the mid-urethral level here, the pressure comes from the top, pressure comes from the bottom, and that area closes and you don't get a leak. If you have weakness in this area, rather than closing this area, this hose pipe or urethra, then just bends a bit. So there is, rather than closing, it just creates a bit of a bend because there's not enough of support here. So there's enough of lumen left for that to leak urine. And that's what it causes stress incontinence. And therefore, obviously, these weaknesses can happen after childbirth or traumatic experience, but it can also happen for people who have repetitive injuries. If you have constant lifting heavy weights, if you are constantly constipated, or obviously some people are born with weak collagen tissues, which are supportive structures, and they do get weakness over the time. Especially if you have sometimes we see the leak when coughing, sneezing, or stress incontinence in younger patients, especially without having children, the younger patients in their late teens or even early 20s, and they have stress incontinence, that because of the weakness in the collagen tissues, which is your supporting structure. So you're basically born with the weakness. So that's what stress incontinence is. Now, the overactivity of the bladder is slightly different. So the stress incontinence, as I explained, is coughing, sneezing, lifting heavy weight, having sexual intercourse, running, jumping up and down. Overactivity of the bladder is slightly different. That is when you get a lot of urgency of waterworks, frequency of waterworks, and you have to go for waterworks often. If you can't read, sometimes you get a leak. And often, if you're referred for mixed incontinence pictures to us, it's not very unusual. We give you something to a bladder diary to fill in, which is 3 days, what you drink, how often you drink, how often you get urge, how often you leak. So typical overactive bladder, because your bladder is not in your control, is trying to squeeze the urine out like this. Now, this typical overactive bladder patients who have urgency and frequency waterworks, you will see they have often going for waterworks, and the amount of fluid that the amount of urine you go and drain every time you go for waterworks is anything between 50 mL to 250 mL. So low volumes and frequent urination, that is kind of a sign of overactive bladder. And bladder diary really helps what you drink, how often you go, and what we can work with you to improve your quality of life. It's all over quality of life. And hence, the first line treatment is always fluid and dietary advice. So fluid is if you're drinking a lot of caffeine, if you're drinking a lot of alcohol, if you're drinking a lot of fizzy drinks, they all irritate the bladder. They all make your bladder full very quickly, and you will have constant going for waterworks often. So modification of what you're drinking is very important. Bladder retraining. So nobody wants to leak in public places, is it? So what happens when we are working or we're going out? Because we have leaking, we don't want to get ourselves embarrassed. We train our mind to keep our water empty, bladder empty all the time. And therefore, it's not very unusual that patients have they have habituated themselves to keep going for waterworks, so that they're going for an hour or two car journey, whether they need it or not, they've trained their bladder to keep emptying. And hence, even with little bit of fluid in, you'll have that cycle of that you need to go for waterworks. You need to go for waterworks. Now, bladder retraining is what Jan and team teaches patients, where they want to make your bladder capacity slightly higher, because constant overactivity can give your bladder capacity smaller. What it also, and I'll let Jan talk about it a bit more in detail. So what they do, especially when you're in a safe space of home, then you can train you've just been to waterworks. The bladder is not that full. Even if you need to go, you need to start thinking, then no, this is not time for me to go. And can I 5-10 minutes extra hold the bladder more? And slowly you will see that this helps to break that loop of bad practices or bad habit you've developed of going for often, and helps you to increase your capacity of bladder. If that doesn't work, obviously then strengthening the pelvic floor will help. If that doesn't work, then we resort to medication. There are basically two kinds of medication for overactivity of the bladder. One which helps to prevent the contraction of the bladder, which is called mirabegron, that prevents the contraction of the bladder. Which helps to prevent the contraction bladder, which is like solifenacin, vesicare, or things like that, which is antimuscarinic. It's good medication to start with. However, it does give side effects like dry mouth, constipation, palpitations, and the side effects do come before actual effect of the medication comes in. So if you can tolerate the side effects of a week or two, then you will see whether there is good results coming up later on. Other medications called mirabegron, it's slightly different. It doesn't prevent the contraction. It helps to relax the bladder a bit more. It doesn't have that side effects of constipation and dry mouth or palpitations. But it's said that when you have onbetmiga or mirabegron, you need to make sure your blood pressure is well controlled. And then if that doesn't work, then we sometimes have to give the Botox, which is to stop the contractions, involuntary contractions of your muscles. And if you really have overactivity of the bladder, then the Botox injections do help. And it does improve the quality of life of the patients. The advantage of Botox, it works really well on overactivity of the bladder. And the disadvantage is that in 1 in 12 women, it relaxes the bladder that much that you are not able to empty the bladder well. So we teach you how to catheterize yourself to empower you in case that is to happen to you. And the Botox eventually will wear off. So you'll have to have this done again anytime between 6 months to 2 years. And it's difficult to predict which patient will need again. The patients who have neurological condition like MS, their loop of the nerves becomes very active. And overactive bladder is very common in MS patients. And you can see when you do a test called urodynamics, the bladder muscles are contracting like this, which are not under your control. And it's more common that we may have to resort to Botox if medication hasn't helped. But it happens to other patients as well. For neurological patients, it's seen more. So we talked about urge incontinence. We come up to the point of what Botox treatment is, and that's how it's done. So what we do is we have a look inside the bladder with a little camera, and that needle goes in, and basically we do a 10-site injection of 1 ml in, but we start with 100 international unit doses of Botox, but sometimes you have to increase it. If that doesn't work, then there are other 2 methods of what is called posterior tibial nerve stimulation, which is like a stimulation of nerve, which is offered privately by Jan here. Yeah. And I'll let Jan talk about a bit more. Second neuromodulation is getting a bit of electrode on your back near the spine, which forms a loop to prevent your contraction of the bladder again and again. Second neuromodulation we don't offer at Benenden, and I'm not sure any of the local NHS hospital offer that as well. But it is sometimes a patient may have to be referred to the tertiary center for this one. And that's if it doesn't get help by Botox. Now, we talked about stress incontinence. So and now the stress incontinence is supported at the mid-urethral level. That's what we're talking about. So again, lifestyle modification is helpful in this. So we have adjusted what you're going to drink and eat, and also reduction of the weight. Because if you are smoking, because we know smokers have, there's enough evidence to say smokers don't heal very well after any procedure, and also your support structures do get weak with smoking. And hence, to get any optimal outcome of the bladder symptoms, cessation of smoking is very important. Second, if you have quite if your weight is on a higher side, try to reduce the weight. There's more and more evidence to say that any incontinence procedure does work better with optimization of the weight with lesser complication. So it's so important to optimization of weight. Then obviously pelvic floor exercises, it does work. And even if it doesn't work, in long term, if you have any procedure or any surgery for any incontinence or prolapse in future, to reduce chance of this happening again, the pelvic floor exercises are so important. So pelvic floor exercises is and should be your best friend if you start having the problem. But even if you don't have a problem now, it's better for doing the pelvic floor exercises to prevent it happening in future. Then there are three, obviously since 2018, all the mesh surgeries for incontinence have been put on hold in England. So there are three mainstays of surgical treatment for stress incontinence. First is called urethral bulking agents, which is popularly known as Bulkamid. It's a local anesthetic permanent gel. So with the first diagram will show, what we do is just at the neck of the bladder level, with the help of the camera, we give 4-site injection. It's a use of a permanent gel, and it bulks that area up or cushions that, which is shown in a second small insect diagram. So that's called Bulkamid. It's a permanent gel. That one, it may need repeating, and in my practice, I only give one top up if it's not properly successful or it reduces success by over the time. If it doesn't work for one top up, then this is not for you. It's successful in 55 to 60% of the patients. The advantage is it's the least invasive option. It can be done in local anesthetic. In fact, my 95 to 96% patient of mine get that done in the local anesthetic, so there's no downtime. The risk is small risk of bleeding infection and small risk of temporary catheter, which is usually 3 to 5 days if it is happening. So it's least invasive, but it's also least successful as well. If you are a woman of a childbearing age, you want to have more children, incontinence is really affecting you, or you are unfit for surgery, then I would prefer Bulkamid over any major surgeries, because doing the major surgery, the first shot of doing the surgery is the best shot. If your repeated surgeries don't work that well, then the surgical options are either autologous rectus fascial sling or corpus suspension. So autologous rectus fascial sling is we give a big cut incision on your tummy, take a 7 to 8 centimeter of what is called a rectus sheath from your body, go through the vagina, and then poke it back again to the tummy. So basically, it forms a sling just next to the neck of the bladder, which is mid-urethral level sling. It supports that. It's a quite invasive surgery, 80 to 85% success rates. Hospital stays only one night. In my practice, I send all the patients home with 7 to 10 days of catheter, and they come back after 7 to 10 days. Jan and her team take the catheter out. 90% of the patients are passing urine well, 80 to 85% success rate, but 1 in 10 patient, because it's an obstructive surgery, 1 in 10 patient may feel that they're passing difficulty in passing the urine, and we again teach you how to catheterize yourselves if the need arises in future, so that you're empowered again and you know that doing intermittent catheterization is not as bad as it sounds. So we do all this pre-op work before we do the operation. And sometimes it's an obstetric operation. Sometimes your bladder do become overactive and we may have to do further medication for you. Last is corpus suspension, where instead of taking the sheet of your body, we go through the tummy. It can be done at laparoscopy or open surgery. Again, we go behind the bone. So behind the bone from the tummy, put the stitches next to the vagina, poke it back to the bone. So all we are doing is now lifting your pelvic floor to give the support again at the mid-urethral level, like this. Similar hospital stays, similar complication to fascial slings, similar success rates, but corpus suspension does result in better support in the front, so hence increases slightly your chance of developing prolapse on the back wall of the vagina in the long term, just to keep in mind, but it's equally good operation.
Thank you. So specialist nurse assessment. So if you're referred to Benenden by your GP with an issue with your bladder, whether that's overactivity or stress incontinence, or something suggestive of having prolapse, you're probably going to find your first appointment is going to be with one of the specialist nurse team. And what we will do is obviously we're going to take a full history, find out what your symptoms are, what bothers you. We're going to test your urine just to make sure you haven't got an underlying urine infection that you're not aware of. We check how you're emptying your bladder. I think, as Mr. Gupta said, if you've got overactivity and you're emptying your bladder every hour, then actually you're going to be passing quite small volumes of urine. Whereas, we want to try and increase that for you, but also to scan your bladder afterwards to check that that bladder is emptying out properly. And that may be a bit of a problem if you've got some prolapse. From the bladder diary that Mr. Gupta talked about, we'll look at what you're drinking. We'll advise you about restricting your caffeines, making sure you have an adequate intake. With overactivity, it's very common for people to say, or if I'm going out, I'm not going to drink. I'm going to cut down on my intake. Again, that's going to put you slightly at risk of getting urine infections. So it's really important to keep your intake, between 1.5 and 2 litres. And we'll give you a bit of dietary advice as well, particularly if constipation might be a problem. We'll work with you on the bladder retraining. So if you're emptying your bladder every hour, we'll try and get you to improve that by 5 minutes, 10 minutes, 20 minutes, 30 minutes. And again, that's all about using your pelvic floor. If when you've got that urge to go, you can squeeze your pelvic floor, just feel yourself, you're getting a little bit of control back in your bladder. And then hopefully, it will just calm that urge down, maybe only for a couple of minutes, but sometimes that can be the difference between getting to the toilet and not having a leak. If you've got symptoms of stress incontinence, the national guidelines are good structured pelvic floor exercises for at least 3 months. So we will do that with you, and then we'll just reassess at 3 months and see how you're getting on. Again, with constipation, we'll help you with dietary advice, maybe any medications. I think, as Mr. Gupta said, it's really important if you are overweight, we'll work with you, with some weight loss, maybe along with your GP, so that if you do need some surgery, we're going to have better outcomes. And we'll also give you advice as well about, exercising. If you've got stress incontinence and you're leaking, what are better exercises to do? That's probably maybe things like swimming, a little bit less maybe aerobics, but then their aerobic exercise is also important to do postmenopausally for your bones. So it's trying to sort of get that balance of what you can do to help manage your symptoms, but also to help you, improve your quality of life. So that diagram there shows your pelvic floor muscle, and the pelvic floor muscle sits like a hammock of muscle. And I always think it's a much bigger muscle than people think it is. So we're going to sort of advise you, we're going to tell you how to strengthen your pelvic floor. And you do something called fast contractions, where you're just going to squeeze it up for a count of 1 and relax it for a count of 1. Those fast contractions are very good for the stress incontinence because it's working that muscle to snatch in quick with those sudden movements. For overactivity and for prolapse, it's more about a squeeze and a hold, which is the strong contractions, trying to hold on. It might only be for a couple of seconds initially, but we're going to hope that we can build on that sort of over 3-4 months with you. And it's really important to make sure you've got the right technique. If you're holding your breath and pulling your tummy in, squeezing your bottom, you're not necessarily squeezing your pelvic floor. So, we'll do an internal vaginal assessment, assess your pelvic floor so that you can be confident that actually what you are doing is the right thing. And as I said earlier, it's at least 3 months to strengthen up those muscles. So don't give up, and we'll be there to give telephone follow-ups, at the end of the phone to support you through this.
So before I talk about the prolapse, again, just building on the pelvic floor, Jan, quite a few patients think that they're doing Pilates, and that means they're doing pelvic floor. Pilates is good exercise, it's core muscles, but they're not only based on the pelvic floor. So even if you do Pilates, you've got room to improve your pelvic floor because they're not only pelvic floor. So just something to keep in mind. So what is prolapse? So we talked about incontinence. So this is a good 2-dimensional picture. So if you imagine, we're looking at the woman from front to back. So first thing you notice is bladder, which is just behind your pubic bone. There's a bladder which drains water out. Then you got behind is the vagina, and that little tube which is draining from the water's bladder is called urethra, and we talked about mid urethral level in the vagina. Then you got vagina, then you got womb, neck of the womb, and behind that is the back passage or rectum. So if the front wall where the bladder is, if that is prolapsing in the vagina, that's called cystocele. If your womb is prolapsing, which is in the second diagram, you can see the womb coming down, that's called uterine prolapse. And if the back wall of the vagina is prolapsing, which is now called rectocele. So that's the human anatomy. So we just explained what the prolapse is. What are the causes of prolapse? It's a weakness of your support structure. So it's basically hernia of your organs through the vagina, because vagina is a hollow organ. So that's basically hernia. And it always happens because of the weakness. And what are the triggers or the causes? Again, smoking is important to say, because chronic smoking, will make your chest bad. So chronic coughing will predispose you to prolapse. But also smokers, they do have weakness of their supporting structures. So they are increasing risk of having the prolapse. Repeated straining from chronic constipation, frequent lifting heavy weights, chronic cough. Obviously, all of us get older, we don't get younger. So so therefore, with time, the supporting structure can get weakened and you can get prolapse. A female body goes through a lot of changes with the menopause, and menopause can make your pelvic floor weak. Traumatic childbirth, we know vaginal birth does stretch your pelvic floor. There is enough evidence to say if you have a forceps delivery, or if you have a traumatic delivery, or a long labor, increases your chance of prolapse. Age we have talked about. Obesity, again, coming back to obesity, is so important for lifestyle adjustment. Obesity can increase the chance of prolapse. Hysterectomy is an interesting one, because it depends on why the hysterectomy is done, for what reasons. So if you have a hysterectomy because of fibroid or heavy periods or something else, because the womb itself has support structures, and if you have the hysterectomy, then it can increase your chance of prolapse in the future. But sometimes you do hysterectomy because the womb is prolapsing anyways. So if you have the hysterectomy for a prolapse, that's because your support structures have already got stretched or weakened. So if your hysterectomy is done for benign reason, not for prolapse, then yes, it can cause increased chance of prolapse. But if the hysterectomy is done already because your organs have, your support structure has got weakened and you're getting prolapse, then different. So there are various indication for hysterectomy, and hence hysterectomy do cause pelvic floor weakness, but it's why you do the hysterectomy and what are the indications. Okay, so treatment for pelvic organ prolapse. If you have a mild or no symptoms, so often patients get referred because you've gone to your GP services, you see a nurse for a smear, for routine. They look at you and say, you got a prolapse, go and see one of the specialists. Any woman who's given birth vaginally will have some weakness of pelvic floor, because the delivery or passage of baby's body and head does weaken pelvic floor a bit. So you will have a bit mild prolapse. It doesn't need treatment if it's not causing you symptoms. So prolapse only needs treatment if it's causing problem to you and to your quality of life. Otherwise, lifestyle changes, which is losing weight, avoiding constipation, stopping smoking, and pelvic floor exercises is all you need for mild prolapse. Also, prolapse which is not causing any problem with quality of life. Hormonal treatment, which is mainly estrogen to the vaginal pessaries, because sometimes you get patients who got a lot of dragging sensation, get examined, thought bit of prolapse, hence the referral. But the prolapse is very small. We can't do any surgical treatment. But the lack of estrogen, which is called at menopause, it's a condition called vulvovaginal atrophy, VVA. That can cause a lot of symptoms. That can cause a lot of dragging, a lot of discomfort, and pelvic floor exercises and a bit of estrogen cream in the vagina really works wonder on this kind of patients. And then pessary comes in various shapes and sizes, which are like ring. They come with a stem, it's called gel horn. It's come with a donut size. It's not for all, where it works in around 1 in 2 patients, so 50% of the patients. It's a symptomatic correction of prolapse, doesn't prevent prolapse getting worse in future, but it's just if it's causing you a problem now. Pessaries need to be changed every 4 to 6 months, and unless you can take the pessary out yourself and put it back again, it can interfere with sexual intercourse. And the last option is surgery. So the aim of surgical treatment is twofold. One is to restore your anatomy and give you good quality of life, and second is restore the functionality of the vaginal tissues. So cystocele, the prolapse in the front, what we do is open the front wall, push the bladder back in, bring the tissues together and suture it back. It's called anterior repair. Similarly, the prolapse on the back is called so now I'm talking about colporrhaphy, which is the third on the top, which is rectocele, which is prolapse on the back. You again open the back wall, bring the muscles together and suture it up. There's repair in the front and the back. For the womb prolapse, if you have the womb itself and is prolapsing, there are the option of a hysterectomy, which is taking the womb and the neck of the womb both out. There are alternative hysterectomy, which are as invasive hysterectomy, if not more, which is one is called sacrospinous fixation, where we stitch the neck of the womb back to a ligament called sacrospinous ligament, or the use of a mesh, which is go through the tummy, put around the neck of the womb, suspend it to the bone. We don't use any mesh. We don't do any mesh surgeries in Benenden because meshes are under high vigilance restriction at the moment from NHS England, and also if you have any complications from mesh surgeries, then we can't solve it at the local level, and then you have to be referred to a mesh center, which is in London. So hence we in my clinical practice, I stay away from meshes, but there is an option of mesh, especially for people who are on the childbearing age group. And if you have the hysterectomy, then you got the vault, which is top of the vagina, is called vault, which is in this diagram. You can see bladder in the front, you can see the back wall in the front. There's no womb, but there's vagina. So this called, sometimes the vagina can come out like this, which you call vault prolapse. If the vault is coming down, there are again two options. The option we offer here is restitching the top of the vagina with a strong ligament called sacrospinous ligament, which is done through the vagina, or other option is a mesh, which again we don't do here. Irrespective of whether you have repairs, you have hysterectomy, you have sacrospinous fixation, hospital stays usually 1 night. Complete recovery will take 4 to 6 weeks. Risk involved is slightest completing an infection, which can happen with any surgery. Infection is common because the operation site is very close to your back wall, and there are a lot of germs in the poo. Bleeding infection, injury to surrounding organs. So if you see, we operate so near to bladder bowel, less than 1% risk, but there is a risk of injury. And 3 things to always keep in mind after a prolapse surgery. Sometimes it can cause pain during intercourse because of scarring. Prolapses can come back in future. Hence, my pleas to keep doing pelvic floor exercises, not lifting heavy weights, not getting constipated, optimizing your weight. And last but not the least, if the front wall prolapse is called cystocele, if it's quite a big, again, my fist as a bladder, tube draining out as a urethra, is kinking the urethra. So once I correct the prolapse, the kink in the urethra is taken care of. What you don't know is how much support you have at the mid-urethral level. So what I'm trying to say here is after the repair of the front wall, if you've got a big prolapse, sometimes it can unmask a bit of leak of waterworks. And in literature, it can happen up to 1 in 20 women. But out of that, 1 or 2 in 100 may require surgical intervention later on. Something to keep in mind. Recurrent urinary tract infection can happen. Again, we talked about menopause, prolapse. If you have diabetes, pregnancy can cause it. And obviously, if you have got a weak immune system or you don't drink enough. So that can cause you recurrent urinary tract infection. Now, the very important bit with recurrent tract infection is if you have recurrent tract infection, if you have to go back to GP for antibiotics after antibiotics, it's worth pushing for sending your V to lab to know what kind of bacteria or microbe microorganism causing this UTI, because depending on what it is causing, they can do a sensitivity test, and therefore we can start you on a targeted antibiotic to help you. Otherwise, just giving 3 days of antibiotic again and again is not very helpful in long term. So recurrent infection, so recurrent proven infection now, what do we do? If you are referred for recurrent infection, we always check your urine to ensure that your urine is clear or not. We check for prolapse, because if you got a big cyst or cell, which is a bladder prolapse, sometimes it can stop you emptying your bladder fully. And we can do a flow and residual when we actually ask you to pee in a pot, see how fast you pee, and then we bladder scan you to see how much you're keeping in. Now, if you're not emptying the bladder well, it creates a reservoir, and you can't, then you get susceptible for infections again and again. This is patients who have big cystocell. If the patient doesn't have big cystocell, then lack of estrogen can increase your chance of feeling cystitis, also with your feeling of infection. So again, hormone cream in the vagina helps. We often get you a scan done for checking your kidneys and bladder. And also sometimes you have to have a look inside the bladder with the camera to make sure you don't have things like diverticulosis or things like stone or things like cancer. And if that's all been ruled out and you keep getting infections, sometimes you do put you on low dose antibiotic, again, depending on what this bug was sensitive to. Sometimes we have to be with patients for 4 months, and sometimes we may have to be with patients for all their life if it doesn't get rid of it. Occasionally, for 3 months, we can use something called Hiprex, which is basically urine antiseptic along with antibiotics. And very occasionally, we may have to go for a bladder installations, which forms a little coat in the bladder to prevent the risk of infections again and again. So these are the resources, and these are the resources for incontinence and prolapse. It's written with patient in mind. So it's worth having click on if the slides are available to you. So you can read various options. We have summarized for you what this means. And then British Society of Urogynecologists, which basically we are all members of. There is a patient information leaflet, which you will find it very useful. The top 3 leaflets are also there on the BSAC website. But it will be you will find it useful to read through, and the options are available. So I thought it's a good idea for us to share this resources with you. And I'll hand over to Jan again.
Lovely, thank you. So we have got a few questions. In fact, there's one quite nice question from a lady who says she's had urge incontinence, but with regular pelvic floor, restricting caffeine and bladder retraining, that has improved a lot, but she does have a bladder prolapse and has had some recent urine infections. So what can I do to avoid the infections, and would the estrogen cream help?
So estrogen cream, if you are we don't know what your age is, so if you are menopausal, then estrogen cream can help with recurrent UTIs. And again, the amount of hormones which come in bloodstream because of local estrogen is very little, so it's fairly very safe. So almost only indication where I check with patients whether you have is if you have breast cancer, then you should get it okayed by your oncologist. Even if your mother had or anyone in your family had it, it's not a contraindication. So estrogen can help, but it also depends on how big is your bladder prolapse and how much is urine you're not able to empty. If you've got a significant grade 2 and above bladder prolapse and you're not able to empty the bladder well, then we may have to do the correction of the bladder, your prolapse, to reduce your chance of infection again and again.
A lady's had a hysterectomy, but could this lead to a prolapse of the bladder?
Yeah, so again, this is the discussion we were having. Depends on what are the reasons for your hysterectomy. If your hysterectomy was done because of heavy periods and you had no prolapse in past, then obviously your support structures which are holding the uterus and some of the pelvic floor gets disturbed with hysterectomy. But if you already have prolapse and the hysterectomy is done because of prolapse, then usually it doesn't increase your chance of a bladder prolapse. However, you might notice that if you had a prolapse from the from the womb, and that's get corrected, different compartments then become more susceptible for prolapse because the one compartment is completely sorted. Then other compartments do have more risk or awareness of prolapse coming down.
There's a question about what treatments are available for a grade 1 cystocele, and hopefully we covered that, but I think for a grade 1 cystocele, we would definitely just be advising pelvic floor muscle exercises, maybe some vaginal estrogen if needed.
Lifestyle adjustments.
Yeah. So with a hysterectomy, are the ovaries generally left behind, and do they still carry on releasing hormones?
It depends on why the hysterectomy is done, to be honest. And if your hysterectomy is done because of the uterine prolapse, we usually don't try to take the ovaries out from the vagina. It's not the common practice. My common practice to take the ovaries out to the vagina. If it's done for the prolapse, if it's done for some other reason, and I'm doing a laparoscopic keyhole hysterectomy and you're open, it's different. But it's for vaginal hysterectomy for prolapse, the ovaries are generally conserved because ovaries are not connected to the uterus; they're higher, and trying to take the ovaries out from vagina becomes more invasive and increases your risk of complications. And they're not. And for the standard vaginal hysterectomy, which is done for prolapse, we don't usually take the ovaries out.
Thank you. A lady's asking about the PTNS. So PTNS, which is the percutaneous tibial nerve stimulation, which is a treatment for overactive bladder. It's not something we do here a lot, but it is available, but it's a private self-pay treatment. So basically, if you imagine the tibial nerve runs from sort of your ankle up to your spine. So the tibial nerve stimulation involves having a very small acupuncture needle just put in the side of your ankle. It's then connected to a machine much the same as like a TENS machine. And it's going to give electrical stimulation through this needle that is obviously going to travel up the needle to sort of where the tibial nerve joins at the base of the spine. It's generally a course of over 12 weeks. And it's quite often sort of, 9-10 weeks before you really notice a lot of improvement. So I think it's one of those things you'd need to come along, have a proper discussion, decide actually, is that the best treatment for you, or are there other things that we can manage to help with overactive bladder? And if that hasn't answered your question, please feel free to email into the specialist nurses. Another question, are there any implications if you have low back problems, if you're having a sacrospinous fixation?
No, if you're having sacrospinous fixation, that shouldn't cause any problem with your back or a disc. We just have to be careful positioning you because the legs are up when you're doing the operation. Sacrospinous fixation does cause buttock ache sometimes, and that's mainly not because of your disc on the back, but it's because the stitch which goes in and reattaches to either the womb or the top of the vagina, that stitch is taken on a ligament called sacrospinous ligament, which you attach to your womb or the top of the vagina. And behind that sacrospinous ligament, there runs a nerve called pudendal nerve. And hence, though your operation is done to the vagina, sometimes you will refer the pain on the right side of the buttock because of the disturbance in pudendal nerve. But it shouldn't cause any problem with your back. No.
Lovely. Thank you. So somebody here thinks that they've got vaginal atrophy. So what's the best thing to be doing?
For vaginal atrophy, as I said, the estrogen, either a pessary or a cream is the best answer. Usually it started as either the cream or a pessary once every night for 2 weeks. And occasionally, if your vaginal atrophy is quite bad, it can take 3 to 4 weeks to reverse. So you may have to have it for every night for 2 to 3 weeks, and then twice or thrice per week to maintain it. Because once you stop, it can go back to where it started from.
And a lady's asking about how you would know if you have urine retention. And that's again one of the things that the specialist nurses would do at your first appointment. We'd probably get you to empty your bladder, and then we have a machine called a bladder scanner that literally just scans over your bladder, and it will pick up if you're leaving urine behind, which obviously is what's called your post-void residual. And depending on if you had prolapse or what your symptoms were, we'd be able to help manage that, hopefully with bladder retraining, double voiding. intermittent catheters if we needed to. But it's one of those things where you just need to come and have a good assessment. Another question is, I've had a bladder biopsy and I have a moderate prolapse. Oh, I've lost that one now. I've had a bladder biopsy and I have moderate prolapse. Will that heal over time? I'm not sure. Does that mean we've had a bladder operation?
I had a bladder biopsy, already have moderate prolapse. There's now ridge on the edge where it was smooth. Would that heal over time? I mean, honestly, this is not normally what happens after bladder biopsy. So I'm not sure you should experience any ridge in the vagina after the bladder biopsy. So it's better to get checked, because bladder biopsy and the ridge in the vagina are completely two different places. So it's better to get checked.
And somebody who said they're trying pelvic floor muscle exercises currently through the NHS. Would it be better to be treated at Benenden? I mean, we work alongside, don't we? So
yeah, it's I don't think it's better to be treated in Benenden or in NHS. I think the treatment is almost going to be the same. It depends on the specialist unit doing your treatment. So we can't give that opinion whether it's better to be treated at Benenden or in NHS. But yeah, it depends on your local NHS hospital. But we are happy to help here.
Yeah, absolutely. And I think sometimes it's around waiting times. A lot of people are still on an NHS waiting list, and if you haven't had an appointment, then obviously we can see you here at Benenden. If you're actually already in the system and you're getting treatment, the advice is probably to stay in with that, particularly if you're not overly local to Benenden.
And I work in NHS. I'm a urogynecologist NHS as well. So the treatment is exactly the same. It's just the waiting times are different.
Yeah. And I've got a lady here's got some rectocele after having a hysterectomy. How long should I continue doing the pelvic floor exercises for? And generally, you need to do good structured pelvic floor for at least 3 months. And then I think it's just about reassessing.
Yeah, I think so.
Yeah.
So 3 months is the minimum.
The minimum.
But I think 3 to 6 months. The way I tell my patients is, if anybody goes to gym and start building up their muscles and start lifting heavy weights, you won't see any difference if you go once or twice a week, and in a four weeks time, you only start noticing difference after you've done it for 2-3 months. And I think that's where your question comes in.
Lovely, thank you. And a lady who's got some prolapse with a history of breast cancer. Is there any benefit in taking estrogen? I think you mentioned before to check with
check with oncologist whether it was whether your breast cancer was hormone receptor positive or negative. But if you have got severe vulvovaginal atrophy, and especially if you had a breast cancer so long ago, I mean, you're 64 now from your letter, from your description, you had it when you were 36 years old, so it's quite a few decades ago. Most of the oncologists will have no problem starting hormones for a short duration of 6 to 8 weeks. They may have some issues by taking it for ever, but then for 8 to 10 weeks, usually they don't have any problems. Especially if you had the breast cancer treatment almost 24, more than 25 years ago.
Lovely. Thank you very much. I'm sorry if we didn't get round to answering all of your questions. And if you provided your name, we will answer your questions by email. Mr. Gupta, can we move to the last slide, please? Thank you very much. So as a thank you for joining our session today, we're offering a 50% off value of your consultation and a callback from your dedicated private patient advisor. Tomorrow, you'll receive an email with a recording of this session and further information, and also some updates on news and future events. We'd also be very grateful if you could please complete the survey at the end of the session to help us shape any future events. If you'd like to discuss or book a consultation, the private patient team can take your calls until 8 p.m. this evening, or between 8 a.m. and 6 p.m. Monday to Friday, using the number that's available on your screen. You can also book a consultation on the website with the discount code, and again, that is on the screen. A link to book will appear once you've submitted your survey. All of our next webinars can also be found on the website. On behalf of Mr. Gupta and the expert team here at Benenden, I'd like to say thank you for joining us today, and we hope to hear from you all very soon. Thank you very much.
Thank you.
Thank you.